れでは時間となりましたので、セミナーを開始させていただきます。本日座長を務めますのは、九州大学アジア・オセアニア研究教育機構気候研究統括の清水修司先生です。清水先生、よろしくお願いします。
はい、どうもありがとうございます。そして皆さん、こんにちは。今日は、ブラウンバックセミナーの2回目になります。で、先ほど、スクリーンの中で紹介があってましたが、ブラウンバックセミナーというのは、ランチを食べながら、気軽に聞いていただくというふうな、スタイルになっておりまして、講演の先生も、専門的な言葉ではなく、分かりやすい形でですね、話をしていただくということになっておりますので、ぜひ楽しみにしていただきたいと思います。今日の、講演の先生は、横田文彦先生、です。で、ポスターやホームページに、略歴が載っておりましたけども、ここで、定例ですので、簡単にご紹介をしたいと思います。このスライドに、まとめてありますので、これをご参照になりながら、説明を聞いていただければと思います。横田先生は1999年に埼玉大学の教育学部を卒業され、ただその在学中にですね、2年間、すいません、在学中に2ヶ月間、インド・カルカッタのマザー・テレサの施設でボランティアをされ、でその後にバックパッカーとしてアジアを中心に世界40カ国をですね、一人旅されたということです。で40カ国というとすごい、国の数になると思いますが、それをきっかけにですね、公衆衛生を学びたいと思われて、アメリカの大学へ留学されています。2002年、カリフォルニア大学ロサンゼルス校で公衆衛生の修士号を、そして2007年にはルイジアナ州チュレーン大学で公衆衛生と熱帯医学の博士号を取得されています。2007年、そのご卒業後、アジア開発銀行や WHO などの国際機関で8年間にわたってパプアニューギニアとインドネシアにおいてエイズや感染症予防調査の国家プロジェクトなどに携わられ、疫学専門家、実務家としてお仕事をされております。九州大学には2015年4月に赴任されまして、当初は持続可能な社会のための決断科学センターというところでお仕事をされてましたが、今年の3月からですね、私どものアジア・オセアニア研究教育機構に研究推進コーディネーター、準教授として赴任をされております。まだこちらのセンターでは1ヶ月ちょっとしか経っておりませんが、今後いろいろと一緒にお仕事をさせていただく予定です。なお、今日はですね、海外からの参加の方が非常に多いということでですね、これからのご発表は英語でされたいということですので、先ほどご案内がありましたように、同時通訳ですとか、日本語のスライドもチャットの中に情報もありますので、日本語でお聞きになりたい、日本語のスライドを見たいと言われる方は、どうぞそちらをご参照いただきたいというふうに思います。そして約25分の講演の予定になっておりますが、時間が予定通りであれば、少しその後に Q&A をさせていただく予定になっております。それでは、横田先生にお願いしたいんですが、今日の演題名は、ポストコロナと超高齢化社会における遠隔予防医療サービスということです。それでは横田先生、よろしくお願いします。
はい。清水先生、ご丁寧なご紹介いただき、誠にありがとうございます。このような機会をいただき大変光栄で、感謝しております。本日は清水先生もおっしゃった通り、海外から、13カ国ぐらいから、200名以上の方に登録をいただき、本当に感謝しております。英語で発表させていただければと存じます。日本語のスライドと、通訳機能をご利用いただけますと幸いです。それではよろしくお願いいたします。またマスクをしながらの発表とさせていただければと存じます。Okay, good afternoon, good morning, and good evening, depending on which country you're from. Sorry, I hear that. Okay. So thank you very much for joining Bag Seminar today. My name is Fumihiko Yokota. I would like to share my slide. Please hold on a minute. Okay. Can everybody see this slide?
はい、見えてます。
Okay. It's such an honor to be able to share my presentation on online healthcare in super aging society in post-COVID-19 Asia. Before my presentation, I'd like to send my prayer to those who are having a difficult time due to COVID-19 pandemic in the world, and those who are working hard in frontline to help them. I hope we can create new ways to keep your family and friends safe, healthy, and happy for better life. And this is a Bag seminar. So I prepared today's presentation to be easy to understand. And I will speak very slowly. And also, I hope you enjoy this seminar. So first, please allow me my first experience of Bag seminar 22 years ago when I was 25 years old, a master graduate student at the UCLA in US. They are my classmates, and we are in group work for a public health class. And they are, what I surprised first time in the US was very diverse cultural background, ethnic background people. They are from different countries, different ethnic background, and different food habit. And as I get to know them more, I become more realized the beauty of diversity and beauty of being different. So I really appreciate today so many diverse audience participating from all over the world. I'm so excited about it. And as an icebreaker, let me show some of the typical brown bag lunch. In the US, we often had a sandwich. And as Shimizu Sensei mentioned, I travel many different countries. So let me show some of the food I had in Asian countries. This is a spicy noodle in Guizhou province in China. This is a sate ayam, sate kambing in Indonesia. This is laksa, Malaysia. This is chapati and dal, vegetarian food in India. This is Bangladeshi river fish and rice. And this is finally a Japanese bento box. So I hope we can have a very meaningful and enjoyable time at this brown bag seminar. So today my seminar is very simple. I will answer three questions. First, what is online healthcare? And our research team and partners, how it's different from other online healthcare system. Secondly, why it's online healthcare will be important for super aged society and the post-COVID-19 era. And finally, how can we continue on on-site research during the COVID-19? How online research can help this situation? Based on the SDGs, on-site, on-demand, public-private partnership, and sector-wide approach. First, I would like to share our homepage. So please wait a minute. I would like to share our homepage. Can anybody see this homepage, our homepage? I would like to introduce our portable health clinic research team in Kyushu University and Asian countries. This is PHC members, advisory, and the core team members, and research members. And originally, it started the collaboration between Kyushu University and Bangladesh. And Dr. Ashir, Dr. Osugi, Dr. Nakashima, and Dr. Maruf are the founder for the portable health clinic. And we joined in 2015 for this project. And since then, we have many overseas partners from India, Thailand, Malaysia, Indonesia, and China. And we are so grateful for that. And our team is, Kyushu University is a very multi-disciplinary team member, including medicine, data science, IT, ICT, nursing, environmental architecture even. In Asia, as I said, there are 6 other partners. Okay, so I would like to show the video to show what is PHC. So if we can go to the homepage and media archives, we can, there are PHC introductory video translated in different languages in Asia, Bengal, Chinese, English, Hindi, Indonesian, Japanese, Malay, Urdu, Thai, and so. So please let me share 2 minutes introductory. Can anybody hear?
As a land of 57,000 square miles of Bangladesh, with more than 160 million populations, people are suffering from various health problems. To overcome the doctor shortage and inadequate medical facilities in the rural areas, Portable Health Clinic (PHC) is a revolutionary invention. This is a joint initiative of Kyushu University, Japan, and Grameen Communications, Bangladesh, to ensure the universal health coverage (UFC). This will bring the healthcare service to the doorsteps of the unreached communities of the developing countries in an affordable and sustainable way. PHC enables physical checkup using automated medical equipment and transfer the vital data directly to the call center, doctors for their reference. PHC measures BMI, blood pressure, body temperature, diabetes, hemoglobin, urine tests, etc. Based on the test results, PHC triage system classifies subjects in 4 categories: green, yellow, orange, and red. Orange and red category subjects are to be connected with their call center doctors through video conference. PHC has been primarily developed for providing basic healthcare services, with a special focus on non-communicable diseases, NCDs, what is the main cause of deaths. However, there are many patients who need other types of secondary or tertiary level of treatment. To address these demands, PHC has gradually added new modules like telepathology, tele-eye care, and maternal and child health care. Recently, COVID-19 module has been added to tackle this pandemic. Bangladesh, PHC has been replicated in many developing countries including Cambodia, India, Indonesia, Liberia, Malaysia, Pakistan, and Thailand. The global healthcare team of Kyushu University has been continuously working with the partners in other countries for further development and expansion of PHC system with the mission of fulfillment of the Sustainable Development Goals, SDGs.
Okay, I will go back to my slide. So please visit our website homepage. So as we watched on the video, the online healthcare research called Portable Health Clinic is the real world solution oriented and the transdisciplinary research, which focus on on-site, on-demand, and social impact. This slide explains on the left, this graph shows what does real-world, solution-oriented transdisciplinary research. First, this research involving not only academic partners, but non-academic partners such as companies, ventures, and government, both local, provincial, community, and national. And we involve from the very beginning of the research when we write a proposal. And this process called co-designing. After we design the project, we will together implement the research. It's called co-production. And then finally, we will do the co-delivery, which means the social impact that research finding will be used widely by the people in the society. And in this transdisciplinary research approach, we have 3 values to share. First is we give more than we take. As we help ourselves, we help others as a global citizen, and we take action. So in this value, how this transdisciplinary research and the portable health clinic can be useful for solving the problem, current and the future. So I'd like to predict the future Asia by 2050 based on the scientific evidence that it shows that in this graph, hierarchy of evidence pyramid in this epidemiological aspect, the higher the data, the lower the risk of bias, and higher the quality of evidence, such as the systematic review. The data come from systematic review or meta-analysis. And if these data are not available, we will use some of the government report, case studies, or some of the expert opinions. And I used this data to predict. This graph shows the percentage of population over 60 years old in Asian country from 1950 to 2050. The vertical axis is percentage, and horizontal axis is the year. And this line shows the countries. For example, the red is Japan. And let's look at the 2050, how the aging population look like. By definition of United Nations and WHO, when the percentage is more than 7%, it's called aging society. If it's more than 14%, it's called aged society. And if it's 21%, it's called super aged society. So in this graph by 2050, as you can see, many of the Asian countries will be super aged or either aged society. And in Japan, I looked at the demographic indicators and economic indicators predicting the future by 2050. For example, life expectancy will be 85 in male and 90 in female in Japan. And healthy life expectancy will be 75 in male, 78 in female. So this trend is similar in Asian countries. The life expectancy is increasing, and healthy life expectancy will be more important indicator because it means we can be productive, we can be workable until, in Japan, for example, 75, which can be retirement will be prolonged. And by 2050, the 500,000 older people will be more than age 100 years old. However, the total population will be decreased to 100 million by 2050. In contrast, the foreign residents in Japan will be increasing to 10 million which consists of 10% of the total population by year 2065. And in terms of the GDP per PPP, the Japan will be number 8 by 2050. So let's predict not only these demographic things, but how about the COVID-19? We want to know how much longer this pandemic will last, when it's end. One article published in the last year, March, said that it will be, the key is a herd immunity. When, for example, in Japan, when the herd percentage of total population required to have herd immunity, if people have a 33% of the population minimum will have a herd immunity, then it will the epidemic will go due to the vaccine. So, and other article, it says not the pandemics typically have two types of endings, not only medical ending like vaccine, but also the social ending. It means that when people ask when this will end, and they're asking about social ending, means they are enough. It's tired. We want to go back to the normal life, and socially it will be gone. Like COVID-19 will become flu or a common cold like. That's according to the historian of medicine at the Johns Hopkins University. But these only the one source of the data. We need to triangulate the data from many different sources and many different indicators to predict what will happen in the future society. But based on the previous existing study, the pandemic at least will last for the next few years. So the social isolation, social distance, the people who feel lonely and depressed, anxiety, fear, dementia, lack of exercise will be increasing in the next few years at least. And in that kind of a society, what we can prepare now to tackle this future problem that we predicted. So next slide, I would like to share one example to show how online healthcare can help for the current and the future problem. This slide shows the portable health online healthcare activities during the COVID-19 pandemic in Indonesia. This is a portable equipment they developed, and they did first the registration for the patient and the questionnaires, and then they checked health checkup, and it's called a population management. Not only the symptomatic patient, but asymptomatic patient or healthy people can have health checkup, and based on the test result, we use the triage system, which can classify the priority of the treatment based on the patient conditions. And those who are healthy or cautious, they don't need to do the telemedicine, but they have report and they get a booklet, and that's it. But those who have red or orange means that they have some health problem, then they can talk to the doctor. It's called doctor to nurse to patient, D2N2P. But in some developing countries, there is no enough health facility staff. So in some developing country, it's called task shifting, that some healthcare workers or some volunteers, trained workers, they can work as a nurse. But they can get, after that, they can get e-prescription that the patient can get the drug at the nearby drugstore. Then they can explain to the patient and then booklet. So this graph shows that we have nearly 50,000 patients ever received this service, and we have published a number of publications and the conference. But this is not our ultimate purpose. We need to how much this our system can be accepted and utilized by the wider community people widely. And this graph shows the technology diffusion of innovation theory, how our system or technology can be accepted by the people in the society. There are 5 types of populations according to this theory: innovators, early adopters, and early majorities who can easily accept and understand the new technologies, innovations. However, there are other peoples, those who are late majority or laggards, who are more conservative, more traditional, and more technology innovative, illiterate. And these people, they need some help, they need some support, and some environmental condition that they only choice, then they can utilize that kind of technologies. And these early adopter innovators tend to be the those who are higher socioeconomic status. And those who are late majority or laggards, they tend to be elderly people and low socioeconomic status. So how this our technology online service can be accepted, understood by the elderly people and other bottom of the pyramid. And so this is this graph shows artificial intelligence and the VR technology at the online healthcare project in China. On the left picture shows that the portable fundus retinal camera, which automatically detect the diabetes retinopathy. And these information were provided by our dear colleague in China. And this technology is already widely used in the rural mountainous minority population in the Guizhou provinces. And the figure on the right side, this is the technology which automatically detect the depression based identifying the brain area which control the emotions. And this one is the facial expressions. By detecting the depressions, then they can treat the depression and the mental health patient using virtual reality, VR. That kind of research they are already doing. And this is another example of the technology development done by our dear colleague in India. Compared to the PCR test for the infectious disease, this device we are developing is lower cost, faster, and on-site testing is enabled by the new technology called isothermal RNA DNA amplification technology. This graph shows the factor influence effective research partnership with Asian our colleagues. I think partnership is key for the success of transdisciplinary research. First factor is understanding the gaps, scaling, framing, priority, accountability, time frame. And the second factor is filling these gaps among stakeholders, among partners, coordinator, sensitivity, social capital, fairness, independent. And this is an example. I visited in India total 16 times from 2017 to 19, and we learned these factors, and then we published this last year, the book. And this is another example. In a partnership, we realized that the agreement, the MOU is so important that we can make stronger understanding of scaling, framing, priority, accountability, time frame. If we have a MOU, and MOU we can also facilitate our sustainable research because it will involve MOU with academic, not only academic, but we can have local government, national government, and the companies. But this process takes time to have a social capital, trust, and I visited from the local to the country level. So this slide shows how we can continue research during the COVID-19. This is an example from Malaysia. Malaysia team, portable health clinic team, they had online trainings and the online pilot test with us, and with the Grameen communications support and also the TEMDEC support. Because we have strong MOU and strong trust and a strong partnership, we could have done it. And this is another example of Bangladesh. During the lockdown, after the lockdown, they keep continuing that. So I'm very grateful for those partners who are working on the ground, the on-site, on-demand. They are demonstrating that. And this is a summary of the process of our experienced sustainable research. First step, we try to understand the gap between researchers and non-research academia, government and businesses, and other field of the research. And we involved in the very early stage of the research, which is the planning stage, designing stage. And these are the people on the ground. And we provide some triggers, and then we reach the agreement. But this process is not that simple. It's go and come back many times. But we need to keep involving with people among the stakeholders. And then until we reach the social impact, that it's synergy of the transdisciplinary research and stakeholders. So I'm very grateful that I could have an opportunity working at QAOS, and Harada Sensei, Shimizu Sensei are such a wonderful professors and very strong team we have. And I would be so grateful that we could work together for the better society in the future. Thank you very much, everyone from Japan and from different countries. Thank you so much.
はい、横田先生、講演ありがとうございました。非常に分かりやすく、いろんな、テーマでというか、最初のいろんな統計を踏まえた動向から、最後 PHC の具体的なところまで、説明してもらってありがとうございました。特に最初のいろんな国のランチっていうのはまず楽しいなと思いながら最初聞かせていただきました。それではですね、いくつか質問が来てますので、先生も見れますかね。いくつか答えていただければというふうに思います。どうでしょう。まずはもう少しインドの研究者の方とのコラボレーションについて詳しく聞かせていただけますか。どこで、レコーディングですね。これはまた別問題ですね。録音が見えますかとか書いてます。それから、continue research during COVID, how we can continue. その COVID-19 のパンデミックの中で、どういうふうにしたら研究が続けられますかとか、あとは、I can see、PhD のことがよく分かったと。 PH can do for improving elderly social network and activities。高齢者のための社会連携や活動にどのように PH が役に立つでしょうか。オンラインプロジェクトはそのためにやってますか。そういう質問がまだまだどんどん来てますが、先生どうでしょう。今みたいなことですとか、目にもうたくさん来だしましたね、最後に。コラボレーション with another country、他の国との連携はどうでしょうかとか、先生、どうでしょう。まだ続々と来てるみたいですけど、何か、質問にお答えいただければと思います。よろしくお願いします。
はい、清水先生、ありがとうございます。そして、質問してくださった皆様、ありがとうございます。最初のご質問、インドの、ご質問なんですけれども、バイオテクノロジーを専門とされている、インドの先生が、糖音 DNA、RNA 増幅手法を用いて、PCR よりもより正確で早くオンサイトでローコストで、検査ができる、感染症の検査ができるというのを開発しておりますので、また改めてご説明させていただきたく存じます。メールか何かでこのチャットボックスに入れていただけましたら、またご返信させていただきます。でどのようにこのコロナの中で続けていけるか、研究を続けていけるかというところで、私たちが気をつけていること、いくつか先ほどもスライドでありましたけれども、まずはその現地のニーズ、こういう状況でどのような研究現場でのニーズがあるのかっていうのを、いろいろオンラインで毎月、毎週ぐらいですね、もう本当、九州大学は清水先生がいたアジア遠隔開発センター、テムデックというのがありまして、そこのサポートいただいても、毎週のように遠隔でですね、現地のパートナーとコミュニケーションさせていただいて、やはりコミュニケーションをしてニーズをまずは理解して、それに対応した、現地との、なんて言うんでしょう、その、MOU、先ほど申しました MOU のような同意をまず決めてやるというのが私たちが今やっているところでございます。で、高齢者の社会のためのどういうふうに PHC かというところなんですけれども、やはり高齢者の方17名をインタビューさせていただきました結果、分かったことは、やはりまだ動ける間は、このようなものは必要ないんじゃないかということでした。足が元気で車が乗れて、病院に行けるんだったら必要ないんではないか。その後、そういうことができない方、例えば被災地の方、または離島の方、またはもう病院に行けないような状態になったときに、やはりこういうのが日本においては必要になってくるのではないか、ということが今の日本では分かっております。また海外とはまたそれぞれの社会構造、ソーシャルストラクチャー、また社会の状況、歴史観とか、そういう社会的要因も踏まえながら、やはり今後理系の先生、文系の先生も一緒になって、研究っていうかコラボできたらと願っております。よろしくお願いいたします。
はい、ありがとうございます。時間は少なくなってきましたが、最後に先生、もう一つ、二つ、質問にごく簡単にお答えいただきたいんですが、一つはですね、他の国、タイの方からも含めてですね、コンタクトポイントを教えてくださいっていうのがありましたが、これはまた、講演が終わった後に、Q&A、いただいた質問の回答を、ホームページで、公開させていただきたいと思いますので、おそらくそこで答えていただいた方がいいんじゃないかと思いますが、日本の方からも、パイロットスタディとか一緒にさせていただけませんかとか、感染や慢性期の分野で何か普及させるポイントがあればっていうのをご質問とか、あとはですね、何が課題でしょうかと、法的なことでしょうか、技術でしょうか、患者さんの対応でしょうか、そういう質問も来ておりますが、先生、いかがでしょうか。簡単にお願いします。
はい、清水先生、ありがとうございます。 やはり社会、先ほど構造と言いましたけれども、やはり社会構造の中でも法律、法制度、例えば遠隔医療に関する法律が整っている国、整ってない国、禁止されている国、いろいろあります。そういう法制度というのがすごく大切になってくると思います。また、そういうマクロレベルの社会構造以外にも、やはりその地域の文化であったり、その村の何か習慣であったりとか、やはりその先生方がやっている研究のスケーリング、コミュニティベースでやりたいか、州レベルでやりたいのか、ナショナルレベルでやりたいのか、そのスケーリングっていうのもすごく研究の目的にもよると思いますけれども、すごく重要になってくるファクターだと思っております。
はい、ありがとうございました。ということで、先生、本当に興味深い講演でしたし、ご質問もいろいろいただきましたけど、先ほども申し上げましたけど、ご質問に対しましては、ホームページの方で改めまして、ご回答をさせていただきたいというふうに思います。それでは時間になりましたので、事務局さんにお返しいたします。よろしくお願いします。
ありがとうございました。
清水先生、横田先生、ありがとうございました。また皆さん、積極的なご参加ありがとうございました。最後に事務局より2点ご案内させていただきます。時間が過ぎておりますけれども、お付き合いいただければ幸いです。まず、次回のブラウンバックセミナーに関してのご案内です。次回は、来週28日水曜日の同じ時間12時10分より、当機構田中俊則先生より、人新世における生物多様性保全、自然保護地域の外をどう守るかについてご講演いただきます。詳細はまた後ほどホームページにも掲載させていただきますので、こちらご確認をよろしくお願いいたします。